Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, and today I'm very excited because finally I was able to recruit a pediatric neurologist to come as a guest on the show. Given how many kids I see with neurological problems, mostly seizures, it's about time. Thank you, Amy Goldstein, for coming on the show. I'm sure we can all benefit from her wisdom. So, welcome, Amy, to the show. Thank you very, very much for coming on the show. I appreciate it. I know you're a very, very busy pediatric neurologist at CHOP, no less. So I know what you do for a living, and I know how busy you are. I appreciate your time. Let me just introduce you to the PEM Rules listeners. Amy Goldstein is a pediatric neurologist at CHOP. She's originally from Cherry Hill, New Jersey, far, far away from here. To me, Amy cannot be any more Pittsburgh than Pittsburgh. She went to medical school at UPMC, after which she completed her residency at the Mercy Hospital in Pittsburgh. And then you pursued your neurology fellowship at Children's Hospital of Pittsburgh, where you stayed and worked for about 15 years as a faculty. Is that right?
That's correct.
Right. And that's when I met you, because I was a fellow around that time at the Children's Hospital of Pittsburgh. And in 2017, when I was still in Pittsburgh, Amy got a position at CHOP and moved there to Philadelphia. She serves as the clinical director of the mitochondrial medicine program. She's a professor of clinical pediatrics at the University of Pennsylvania, works for the Department of Pediatrics, Division of Human Genetics, with a secondary appointment in the Department of Neurology. Cannot be any more specific than that. And Amy, you have published about 80 research papers and research articles. Is that right?
Yes, that's right.
Amazing. And I know you have specific focus on mitochondrial diseases, correct?
Yes.
Fantastic. So again, thank you, Amy, for coming on the show. How are you?
I'm doing great. Thank you. Thanks for having me.
Oh, you're very welcome. And I got to say, I'm a little embarrassed after, every once in a while I listen to my own podcast, and it dawned on me that among all the subspecialists that I've hosted on the show, I have yet to host a pediatric neurologist. And kids with seizures specifically, or neurological complaints, is something I see all the time. So I think my listeners will clearly benefit from your wisdom today. And my first question to you, Amy, is a question I ask all my guests on PEM Rules, and everybody has their own answer, which is great. First question, what is your definition of a good PEM physician? One who does what?
Yeah, I really am pretty amazed at people who do emergency medicine. I think, you certainly need to know a broad range of medicine, but you really need to be able to be very confident and keep your composure and think fast, making the right decisions very quickly, and be able to multitask and be ready for anything that walks in the door.
Very good. I agree with that. Sometimes easier said than done. Kind of goes back to some of my rules. A good PEM physician is always a step ahead. I try to keep that in mind. And being calm, cool, and collected, it's certainly something that I try to focus on during the shift. Again, sometimes easier said than done, but I appreciate it. Thank you very much. And again, sort of goes back to what I wanted to talk to you about, Amy. One of the things I really wanted to talk to you about, and I cannot possibly host a child neurologist, pediatric neurologist, in a pediatric emergency medicine podcast without speaking about febrile seizures, which is something that here in Vegas, I think I see every shift.
Mm-hmm.
It's a chief complaint that floods our ED. And over the years, I got to do a lot of reading on the topic. I actually presented some lectures on the topic. And I gotta be honest, it's still unclear to me. And it seems that the science is a little unclear about the relationship of the fever with the actual seizures. I've come across some studies where patients with the first febrile seizures received low-dose phenobarbital scheduled, or low-dose benzodiazepines scheduled, and still got a febrile seizures. I've come across studies that kids were treated, again, with scheduled Tylenol, keeping their temperature at bay and still got a febrile seizure. So can you maybe shed some light to this question? Is treating the fever with scheduled Motrin or Tylenol really prevent the next seizure? Is that something we should recommend to the parents? What anticipatory guidance should we give those poor parents who are so frustrated and afraid?
Yeah, sure. That's a great question. And, as a pediatric neurologist, we got plenty of phone calls from the emergency room as consultants, right? Like, what should we do? There's a kid here who had a febrile seizure. So there is a wonderful consensus statement from the American Academy of Pediatrics from 2011 that still stands, which again, we need to make sure we're speaking about simple febrile seizures, children that fall within the parameters of those recommendations. So this has to be a child that is otherwise healthy, that never had a seizure without fever, that's developmentally normal, and that is between 6 months old and 5 years old. Again, so those ages are very important. And a lot of questions pertain to the workup, right? What should we do? Does this kid need a spinal tap? Does this kid need blood work? Does this kid need imaging? What do we need to do for the child as workup? And then what do we need to do for prevention? And, keeping in mind, seizures look really scary. These parents are usually very, very frightened. And then once in a while, you get, the mass media that captures a story that has a really horrendous outcome. And then you have frightened parents that have read the latest in People magazine or something like that. So parents need a lot of reassurance, right? Because febrile seizures are not uncommon. Like you said, you probably encounter one a shift, right? So what we know is that, again, these are very common, that simple febrile seizures are seizures that are under 15 minutes in duration, that are not focal in any way. This is a generalized seizure that is limited, right, in time, that it ends on its own, and that it does not recur within 24 hours. And a lot of the treatments that have been proposed try to get after the limiting the recurrence of the seizure, so that you're not having more than one in that 24-hour period. But if you have a kid, let's say with otitis media, well, we know that fever's likely to keep recurring. And even if that kid gets started on antibiotics, that infection's not necessarily going away immediately. If they have a viral infection, the fever's not going away immediately. So some children do have recurrence of that fever and may have recurrence of that seizure in that time frame. And so again, some of the treatments have been proposed to help limit recurrence of that seizure if that's that child's pattern. So getting back to the workup, because I do think that this is important, the biggest question that we get is, again, do we need blood work? If that child comes in and they've had a viral gastroenteritis and they're really dehydrated, that's a kid that you would, question, do they need blood work for the gastroenteritis? So this is where you can use your emergency medicine knowledge and say, would I be working this kid up for the gastroenteritis? If your answer is yes, if they look dry, you're going to do labs and treat appropriately. So the workup really is centered on the fever, not so much on the seizure, right? Does this kid need a chest x-ray? Do I think they have pneumonia? Is that what's causing the fever? They may need an LP if they have signs and symptoms of meningitis, right? Nuchal rigidity, all of that. But then the other issue is if they are between 6 and 12 months and they have not been immunized for Haemophilus influenza or strep pneumo, or if they have been on antibiotics and they are partially treated, if there's a concern for that, then there are recommendations to do an LP because you cannot be guaranteed that they are not walking around with meningitis. So I think that's a big issue that a lot of us talk about, right? Like, do we need to make sure that they don't have meningitis? So those are kind of the big red flags for, does this child need to be worked up in terms of the emergency room? And again, the imaging question is only if they have something strange going on. Do they have a focal neuro exam at that time where we're concerned that they may need to be imaged? But if the kid looks good and their exam looks good and they are back to baseline, then imaging is not warranted for that child. So getting back to your question about treatment, the antipyretics question is something that a lot of parents will try, and it doesn't work. And it doesn't work because the seizure happens with the rapid rise in the temperature. Right. And so most of the time when children have that seizure, it's that the temperature is very quickly rising or even quickly declining. And we really tell parents, don't put them in an ice bath. That'll create shivering. That will cause a decline in the temperature too quickly. They can put warm compresses, like slightly warm water, not hot water, not freezing cold water, but warm water under the armpits, on the stomach, or put them in a lukewarm bath if they want to help reduce the fever. There are papers that have talked about trying to do scheduled Tylenol, Motrin around the clock. And we recommend that to help with the fever for the child's comfort, but it's not necessarily going to help reduce the seizure. Phenobarbital is not what we recommend, mainly because a lot of children get very sedated on phenobarbital, and then you've taken away your mental status exam. And if you bring a kid to the emergency room and you're trying to evaluate whether their mental status is intact, whether you need to do an LP or not, you've just lost your exam. And so that is not something that is recommended. There have been other studies that have looked at, well, what about Depakote or Keppra, and seizure medications, maintenance seizure medications are not recommended for febrile seizures. There are a group of children, as I mentioned earlier, that have recurrent febrile seizures during that febrile seizure window, where they, during febrile illnesses, they may have recurrence of seizures. So there are a few kids that may get scheduled Klonopin, where they get low dose, a clonazepam or, another low dose benzo scheduled for 3 to 5 days during a febrile illness. And some kids do really well on that. Again, this is a very individual decision based on how the parents feel about it, based on how the kid does historically, because not every child has 2 or 3 seizures every day during a febrile illness. So it's really reserved for those kids that have recurrence for a couple of days during that febrile illness, and they've already kind of proven that pattern. And then there are other kids that may have prolonged febrile seizures during a febrile illness. So those kids that tend to go 5-10 minutes, and we don't want them having a prolonged febrile seizure. And those are the kids that may get a prescription for rectal or nasal diazepam or midazolam that, end up, we want to give the parents a rescue drug to have on hand at home so they don't have to call 911. So that's a lot, having said all of that. And again, that practice parameter from the AAP is also really, really helpful. And just also to mention, a lot of hospitals have come up with practice pathways that are available online. CHOP has a febrile seizure pathway, but I think other hospital systems, I think Atlanta, the Children's Hospital System of Atlanta may have one. And so those are also very good resources to check out online.
Excellent. So, no, thank you very much. So this is really valuable information to us PEM providers, kind of confirms some of the things I know, but a lot of new information. So that's really, really great. Again, extremely, like you said, scary chief complaint for parents, experience for the parents, and certainly a frustrating experience to some physicians who really don't have a lot to offer. So yeah, thank you very much for that information. My second question to you, and again, another frustrating situation for parents and physicians, is those patients who come to the ER, and again, I see this pretty much on a weekly basis, a patient that comes in from school or from home with a very compelling HPI for seizure, again, happening at school or at home. So it's like a 5 or 7 or an 8-year-old who mom said dropped to the floor, had tonic-clonic-like movement, bit his tongue, had urinary incontinence, lasted 5 minutes or however, it looks like forever, and then called EMS. By the time EMS comes post-tictal, by the time they come to me, they look totally fine. But the story is, again, very compelling for a seizure. Sometimes the EMS watched it, etc. And over the years, I've seen a lot of practice variation for those kids. In my fellowship in Pittsburgh, there were very clear guidelines that if the child was back to normal, that has to happen, had no evidence of head injury, meaning does not need a head CT, had no vomiting, so there's no concern for glucose or sodium issues, had a non-focal exam and back to normal with no family history. We used to get EKG on those kids to rule out arrhythmia, because arrhythmia can be a dangerous thing, although it's super rare. and discharge those kids. And in Pittsburgh, there was a system called the rapid referral. I'm not sure they still have them. So the patient will see the neurologist, hopefully within a few days, but those patients went home. And again, as I said, over the years, I've seen a significant variation in physician practice and comfort level for those patients, with a lot of patients get what I called screening labs, which is kind of a terrible name. I'm not sure there's a relationship between a CBC and a seizure. Maybe I'm wrong. A lot of patients get head CT, which is normal 99% of the time. And I certainly do think it's a hard sell for a parent to send their kid home after they had a seizure, but some kids get admitted, and I've been at fault for that. Sometimes I did admit those parents for observation with consulting with neurology that will do an EEG the next day. But tell us, Amy, what can you tell us about the appropriate, so to speak, workup for a child who seemed to have a seizure, but he or she are back to normal?
Yeah, I think this is, again, a really delicate scenario, because you have parents that may or may not have witnessed the event. If it happened at school, they're going by the reports. And seizures, again, they're very, very scary to watch, and it can be really difficult to reassure parents. But the other thing that we need to remember is that seizures are not uncommon. We know that somewhere between 25 to 50,000 children are going to have a seizure, their first seizure ever, every year, right? And a number of children will have one single seizure and never have another seizure ever again. And so really, when we are evaluating a child with a seizure, the biggest question we are trying to answer is recurrence risk. Right? Will this child have another seizure? Was this provoked, and will it happen again? And that's why we do a workup, right? Was there hypoglycemia? Was there a cardiac issue here? Was this convulsive syncope? What was there anything else that could have provoked this? And what's the recurrence risk? And most importantly, does this child need to be on medication? And most child neurologists will not put a child on a seizure medication after the first seizure unless the EEG is so floridly abnormal that it is only a matter of time. And a lot of us will still wait for a second event to happen, because the EEG can be abnormal. And, we know that there's a percentage of people that walk around with an abnormal EEG and won't have a clinical event. So doing the EEG right away is not necessarily a good thing. Right after a seizure, the EEG could be slow, and that will be a postictal finding. So it's actually a good idea to wait a few days right after to let that EEG kind of clear up and get it in an interictal period, because it can be really difficult to interpret the EEG right away if you get it immediately postictal. So again, if the child is completely back to baseline, I would really try to get that kid out of there, because it's better to do this as an outpatient workup, right? If there's any question that that child's not back to themselves, then, obviously we have more work to do, right? If that kid has a focal exam, if they're still altered, more needs to be done. This is when, if you have neurology to come down and consult or to admit to, then, that's the role at that time. Labs, again, you kind of addressed this, is there a role to get any labs? And this is also where it gets tricky, right? If the child's coming in via ambulance, a lot of times they'll do a glucose stick en route. But we know if that kid's had a generalized tonic-clonic seizure out in the field, what happens during a seizure, there's a lot of adrenaline being released. So even if they were hypoglycemic at the time of the event, they've now just released so much epinephrine that, the glucose is now going to be high. So that's something that we've always debated. The paramedics may say, well, we did a finger stick, the glucose was 90. And I'm like, what was it before the event? So you get into that debate, like you'll never know, was the kid 40 at the time of the seizure? You don't know. But most of the time, the kid does not need labs unless there's something suspicious going on. Again, were they having some kind of viral issue, diarrhea, dehydration, that kind of thing? Was it provoked? For the younger kids, or even this age group, is there any concern that there was some type of toxicology issue, right? Was there a pill swallowed or anything like that? So tox screen could be considered, right? If there was some possibility that something was ingested. EKG, I think, is always something to consider, especially when, let's say the kid was running around, it was gym, and they went down and nobody knows what happened, right? That's always something that we worry about. But we may be doing a lot of EKGs to find that 1 in a million. But I would say that most cases, these are non-urgent workups, with exceptions. And there's a list of concerning features, right? And the concerning features, again, are this was not a normal child to begin with. There's been some regression in the history. It's a young kid, right? Somebody under 2 with the first seizure, a history of intellectual disability, right? Any other red flags. And again, here, there's a wonderful practice parameter, which again is years old already. This is from the year 2000, and this was a joint effort with the American Academy of Neurology, the Child Neurology Society, the American Epilepsy Society, jointly made a statement. And again, this has stood the test of time. It's 23 years old, and it's available online, where they came up with practice parameters. And again, this is through scouting tons of literature coming up with what should be done for the first unprovoked seizure in children. And there's a sister document looking at what should be done for first seizure in adults as well, if people are interested in looking at that one. And it goes through, what about EEG, what about imaging? And I don't even think they included EKG in that paper. And then what about labs? And should this be done urgently versus non-urgently? And again, there are also online practice guidelines, pathways for this to be used in the emergency room, both from CHOP as well as from other hospitals, that can be, again, very, very helpful to follow in the ER with algorithms that are very easily laid out.
Very good. What about the question of the day, head CT?
So head CT, I don't think, unless there's a concern, did this kid fall and smack their head where we have an acute head trauma on our hands? Or is there any concern on exam that there could be a space-occupying lesion that caused the seizure?
Very good. So again, that's something that I see quite often. Not what I learned, so I try to discourage the residents and the fellows from going down that route, or general ED docs who call me before transfer. And I'm glad for all that information. Again, very, very helpful. Something we see all the time. One last question, Amy, and I think that's something that you can really help us PEM clinicians, because I know you have a big passion and have done a lot of work on mitochondrial diseases. And mitochondrial diseases is not something I see very commonly. But tell us, Amy, when we see a child with a mitochondrial disease in the pediatric emergency department with chief complaint X, what are the red flags we should look for? What are kids with mitochondrial disease at risk for? Are they immunocompromised? Are they at risk for respiratory failure? What should we worry about? What should we check for?
Yeah, it's a great question. So, people may or may not be familiar with mitochondrial disease, and the issue that we have is that they may come in with one problem, and then what gets uncovered pretty quickly is they have many other problems. And so one of the things that I've worked really hard on is I actually developed a pathway. I've been talking about CHOP pathways here, but I developed a pathway for our emergency room because this became an issue for us, right? A child might come into our emergency room and our ER wasn't sure, what should I be looking for? So children with mitochondrial disease, and again, just briefly, mitochondrial diseases are genetic issues where children have a disorder of energy metabolism. So the mitochondria are not generating enough energy for the organ systems to run properly. So this predominantly affects the nervous system, right? Children can have developmental delay, seizures, stroke-like episodes, myopathies, weakness, cardiomyopathy and arrhythmias. They can have external ophthalmoplegia, vision issues, so ptosis, retinal problems, hearing loss. So again, a multitude of problems. And then the other issues they can have involve their kidneys, so kidney clearance or kidney failure, and endocrine issues. So we can have a child that comes to the emergency room, and let's say they have a history of hearing loss, vision concerns, arrhythmia, but they can come in DKA for the first time. And so they may come in with altered mental status, and then it's like, well, are they having a seizure? And we can get labs, and they can have low sodium, high potassium, low calcium. I mean, it's been really challenging because depending on what syndrome they have, I'm trying to tailor the emergency room letters now to really help point our emergency room as to what should they be looking for. So if a child has, again, there's a syndrome called Kern-Serre syndrome where my patients keep coming in either dizzy or sleepy. So I really have to point our emergency room at, okay, let's first look at electrolytes because they've had profound hyponatremia or hypoglycemia or hypocalcemia. And if we first check that, then we have to get an EKG to make sure they're not in some kind of arrhythmia, but they might have a pacemaker in already. Okay, if it's not that, let's get an EEG on them to make sure they're not having a seizure. And, it's kind of the stepwise type of thing because any of the organ systems can be wrong. But if you don't know what they can present with, it can be very challenging. So I've had to kind of lay out here all the possible symptoms and let's go through them one by one, kind of in order of priority and kind of check off the list because the symptoms might be very vague. Right? Like Jimmy he's not acting like his normal self. Where do you even go from there? Right? Or they're just a little fatigued or a little off balance. Right. It's like, well, and you can tell from looking at that child, they're not at their baseline, but they're also not normal to begin with. And so it can be very challenging. And if you practice at an emergency room where it's a pretty common vacation destination site like Orlando or Las Vegas, you're going to see families from all over the country or all over the world walking in with maybe, a physician letter from anywhere saying, can you please follow this protocol? And it can be really challenging. So it's helpful to kind of either have a letter or a pathway so you kind of get a sense of where do I even begin?
Yeah, so I think another thing I teach the residents or the fellow is ask the parents, Mom and Dad, your child has syndrome X. I don't know much about it, to be honest. What medical problems has he or she had secondary to that syndrome? Do they have a heart problem? Do they have a kidney problem? And oftentimes, when you simplify it like that, the parents do know, and that's very helpful. So, thank you for that. Those are really, really great tips. And I don't know if you remember that, but like you said, vacation destination several years ago, I saw a patient in Orlando who were visiting from Pittsburgh, and they have a mitochondrial disease. And I remembered sometimes during the HPI, I say, oh, do you happen to know Emmy Goldstein? And they're like, oh, yeah, Emmy Goldstein is my pediatric neurologist. So, yeah, I remember that day very well. How many pediatric neurologists can say, how many pediatric emergency physicians can say, I saw this patient that I know whose neurologist works in Pittsburgh? That was very entertaining. Amy, thank you very, very much for coming on the show. Those, again, really great information for us PEM providers. I really, really appreciate your time. As you probably know, hopefully you know, there's a tradition on PEM Rules where the person I interview gets to choose the outro, and I guess you wanted to hear Snow Patrol by Chasing Cars?
Yes, absolutely.
All right. I got to say, I didn't remember the name of the song. I looked it up, and I do know that song very well. I think it was also in the 90s somewhere when I was a teenager. It's a great song. So I'm going to do my very best to get that on the guitar for you.
Okay, thank you. Thanks for having me on the show.
Thank you, Amy. Thanks for coming on the show, and have a great day.
You too. Thanks so much.
And that is it for today, guys. Thank you very much for listening to PEM Rules. Thank you for checking the website, the Facebook page, and leaving your comments. Again, if you want to come on the show because you have some rules of your own or because you have some patients that you saw recently that are very interesting and you applied the rules, just let me know through the website, pemrules.com, and I'll be more than happy to have you. This is Chasing Cars by Snow Patrol as requested by Amy. Thank you, guys. Have a great day.